Welcome to the New Dentist Study Club podcast. My name is Dr. Sanj Mohanta. We're going to learn about clinical management, practice management, and the emotional management of dentistry. Let's learn how to be happier in dentistry. Let's go. Thank you to our sponsors, Altum Dental Lab Group and RDT Dental Lab in Toronto. Hello, my friends. Welcome back to the podcast. This is a very special episode because it has a very special person, my friend Sara. She is an endodontist. Not only that, she is a mother of a young girl and she owns a beautiful office in Toronto. She's killing it in everything she does, and she's going to teach us about everything we want to know about endo. So, Sara, welcome to the pod.
Thank you for having me, and thank you for such a nice introduction. I appreciate
You're
it. Making me
welcome.
blush over here.
So tell us everything about yourself, starting with pronunciation of your last name.
Yeah, so my last name is Serbian. My dad's Serbian. I was born in
Okay.
Serbia, so it's Markovic.
Markovic. Okay.
I moved to Toronto when I was 3 years old, grew up in Rexdale, and then later on in Midtown. From there, I did the majority of my education and training in the US. So I moved to initially Boston for undergrad, and then I was in Chicago for a master's degree, and then NYU for dental school, and then University of Florida for my residency. So I moved around quite a bit, but I was a non-traditional student. So initially I started off my career working in mental health for a nonprofit. So I was a residential counselor at a group home, working with 18 to 24-year-olds in the field of mental health. And then after that, I decided that I want to potentially go into psychology or kind of pursue that area, maybe go into psychiatry. So I moved to Chicago and did like a pre-health program to do all my science classes, because originally I was in the humanities. I went to liberal arts school, so I went to Tufts. So a small liberal arts college, and focused on clinical psychology. So I ended up doing this pre-health program, and during that process, I did a couple art classes, including one on like making jewelry and things like that. So I kind of started working with my hands a little bit, and then I also ended up getting into ethics, healthcare ethics specifically. And a part of that program, while I was getting my master's in healthcare ethics, was dental ethics. So that was kind of my first exposure to dentistry. So I ended up getting my master's in ethics and applied philosophy, and then I worked in a hospital setting, and I was debating about going into psychiatry or potentially in the health fields. So I was working in a hospital, working in like end-of-life care. And after that experience, I was discussing informed consent and patients' kind of end-of-life treatment planning. After working with the residents, I just said, you know what, this isn't for me. I know I want to be in healthcare. I know I want to work with people, but I need something a bit lighter, something where I can make an impact and in a positive way, but also, just use my hands, use different aspects of my personality. So that's how I ended up thinking about applying into dentistry, kind of on a whim at the age of 29. And it just, everything happened very quickly. Ended up going to NYU, and then did a GPR after that, and then went into general dentistry, and then later decided to specialize with some help from a mentor that kind of recommended that I go in that route.
Sara, that is the craziest dental backstory I ever heard. Like, you could have been a psychiatrist right now or selling jewelry on Etsy, but you're an endodontist. So
Yeah,
fortunate for our patients, you're an endodontist. So thank you for that crazy story. I'm glad that it led you to, the perfect path for yourself.
yeah,
So
thank you.
let's dive into endo.
Yes.
So first of all, you talked about informed consent. How do
Yes.
you have that discussion with your patients?
Yeah, so definitely think a large component of proposing the treatment plan is going over kind of the risks, the complications, what are the prognosis for the treatment. So typically, I'll first go do a thorough diagnosis so that I can have an idea of what we're dealing with. Also gain a sense of the patient's compliance, their cooperation, what is the issue in terms of finances, because all of those things will factor into informed consent. So, starting to get a kind of develop that relationship and that rapport, and kind of knowing where the patients are coming from and what their perspective is on saving their tooth. Because sometimes I'll have a patient that, really is indifferent. And finances might be a huge factor. So at that point, I give them the information, but maybe with not the same depth, because they're not that interested. They don't necessarily care about the statistics. Some patients I have want a very, very good prognosis, whereas other patients I have might be okay with a 50% chance, and they have a crack in their tooth. And I've told them that, it's unpredictable. So I think the big thing about informed consent is having an idea of the therapeutic relationship, how your patient feels about their teeth, and how much they're willing to invest. And also managing expectations. That's a big portion of when I'm going over informed consent. So I can tell you a couple things that I highlight in my informed consent documents. So the first thing is I do talk about prognosis for a for a non-surgical root canal. So approximately 89 to 95% over a 10-year time period, depending on what study you look at. So I mentioned that to the patient, and I say to them, what that means is that every once in a while, when I see you for a checkup in a year, there might be an issue. So, this isn't 100% guarantee, but certainly our goal is to save your tooth. But depending on your immune system, the bacteria that is causing this problem, and different factors about your tooth in terms of your root canal, the complexity, the curvature, how many canals, things like that, that may impact the prognosis of your tooth. So I think it's really important for dentists that we also emphasize that it's not all about the skills that we have. There's a large component of healing that has to do with the patient's immune system, their host response, the bacteria. Sometimes the bacteria is resistant to treatment. Maybe they need a surgery. Maybe they have a cyst. That's not going to necessarily heal all the time with conventional root canal. So I definitely discuss those things ahead of time. And then I also go through the statistics of what can happen. So 1% of the time we might have a perforation. And again, this isn't specific to me. It's based on studies done on all dentists.
Okay.
File separation, again, happens 1% of the time. But that has to do with your tooth. We use very flexible materials, but if your tooth is very curved, they can't handle the stress. So mentioning those kind of things, but also mentioning that most of the time doesn't impact the treatment outcome. This is something I'm going to discuss with you, and I will tell you if it happens, but we're just going to monitor you if it does, because most of the time, nothing bad happens. So just being honest and explaining things. I often provide a pamphlet in terms of information, or a link that they can watch a video if they want more information, for some of my patients that are more detail oriented. Whereas I have other patients that are like, yeah, let's get this over with. And they don't want to really discuss it. But I think even in those patients, it's still important to highlight the important factors, like the possible complications, as well as the long-term outcome and the need to follow up. This isn't just okay, you're done. We also have to follow up annually to make sure that healing has happened.
That's fantastic, Sarah. I love the fact that you talk about prognosis, stats. They say that even if we do a perfect root canal, it may not be successful because, your body has a part to play in it too. And that probably takes the stress off of you as well. Because
Yeah.
when a root canal fails, you don't think that, oh, I better, refund my patient, or, oh, it's my fault. What did I do wrong?
And that's exactly it. I think a lot of us are perfectionists in this field. And I think it's important to take a step back and look at it as any other healthcare professional. We work with physiotherapists often. I've seen that you're not always going to be able to cure your patient. And there's so many different factors that go into it that are, even if I do a perfect root canal, sometimes it fails. On the other hand, sometimes I might have a very blocked or ledged canal, and the root canal looks awful, but it works. So,
Yeah.
we have to take a little bit of the responsibility off of us in terms of healing, because a big component of that, it has to do with the patient's immune system and the tooth, right? And we
That's
have no
great.
control over that, right? Yeah.
Thank you.
Yeah.
And then how about diagnosis? Do you like what percentage of the time are you using CBCT or are you using traditional radiographs most of the time?
Yeah, so most of the time I'm using traditional radiographs
Okay.
and just doing my typical testing with endo ice, EPT if it's questionable, I need to
Okay.
confirm a diagnosis, and a bite stick to check the bite, or if there's a potential crack, see if there's pain on release. And perioprobing is very important too. A
Okay.
caveat to that is sometimes if you do see a deep pocket, you can freeze the patient and do your periprobing because sometimes we're really scared to probe because we know it's uncomfortable, but it might impact the outcome, especially if a
Mm,
crack is suspected. Really important to get an accurate periprobing in terms of determining the long-term outcome of a cracked tooth. So, in terms of doing our diagnosis, just a traditional, PA is great. When do I do CBCT? When there's something questionable, or I know there is something with the anatomy that is very complex, or if I think it might be a resorption case. So if it's something out of the norm where I need additional information, or it's inconclusive, so my tests are telling me
mm.
something very different from what I'm seeing on the traditional PA, then I'm going to go to the CBCT.
Okay.
Yeah.
And then can you tell us how you do your endo ice test? And
Yeah.
then what's considered normal or what's considered like an apical periodontitis?
Yeah. So typically I use like a size 2 cotton pellet, which is kind of a chubbier cotton pellet. So it's a pretty big size. I will spray that with endo ice until there's crystallization. And
Okay.
I respray it with each tooth. I always do baseline testing around the teeth. So the whole quadrant I'll do. And
Okay.
I'll just start off and tell the patient, I'm going to test all your teeth in this area. I'm going to start with a healthy tooth so we can, ascertain what your baseline is, what's normal for you, because it varies from patient to patient. And then I just, go ahead and put the pellet on the tooth, have the patient raise their hand, and then put their hand down when the cold dissipates. Engage what's normal for them. And then I'll go to the tooth in question. And, a lot of times patients don't want to let you do it because it's uncomfortable. But I emphasize that it's extremely important because
Okay.
this is the most diagnostic test clinically that we can do. So typically, what determines that fine line between like a reversible pulpitis versus irreversible
Mhm.
pulpitis? I would say it's time. So if it's
Okay.
quite substantially different from the other teeth I tested, then I'm like, okay, this makes sense along with the x-ray. So along with all the pieces of evidence, this makes
Okay.
sense. Very exaggerated, not necessarily. If it's exaggerated and
Mm.
lingering, then so it's mainly the time factor, the lingering,
Okay.
or no response, right? One thing I noticed though, sometimes with even at U of T with some of the students I'm working with, a lot of times they aren't testing the other teeth to see if they have a response. And especially with older patients that have a lot of calcification, all the teeth will test, they won't have a response to endo ice.
Okay.
So, the fact that you tested the one tooth and it didn't have a response is actually insignificant because it's inconclusive because the other teeth also aren't responding. And I see
Okay.
that quite a bit. So in those cases, I'll go to EPT and use that to confirm.
Most of us don't have an EPT. Can you
Yes.
explain how that works and what number is normal, what's abnormal?
Yeah. So again, the numbers are really not that significant. It's just if you have a response or not. The numbers are just how high I have to turn it in order for some people vary. So people who are super sensitive, they might feel it right away. Other patients, I get close to the highest setting and then they feel it. So typically what you do is you want to ground it. So it's a lot like an apex locator. So you put the lip clip on, and then you put a little bit of toothpaste on a probe that's attached to this electrical meter, and then you turn it on the lowest setting because it's actually really uncomfortable and unpleasant. And then you would test a healthy tooth first, and then you would go to the tooth in question. And again, I only use it in cases where there's something off,
Mm.
inconclusive, a trauma case. Because a lot of times in trauma cases, especially in younger people, there will be a period after the trauma where they won't really respond to endo ice or even may
Mm.
not in the future. But when you do EPT, they do respond. Um, but again, even in those cases, every once in a while, you might get a false positive. So it's really
Mm.
putting the pieces together with the x-ray. If the tooth has color change, if it's also, sensitive to percussion, even though you're getting this inconsistent reading, they are feeling endoitis,
Mm,
they are feeling EPT, they're not, but typically with EPT, they will jump out of it. It's really uncomfortable. So
wow.
if they have that response, then I'm pretty confident that this is accurate. If they're not really, oh, I think I felt a tingle. No, that's most likely
Okay.
inaccurate. Yeah, yeah,
Okay, good. And you
yeah.
mentioned the apex locator. Is the apex locator ever wrong?
So I would say very rarely.
Okay.
However, there are certain factors that may make your results a little less reliable, mainly like liquids. So make sure that you suction out like any hypo or any heat, like blood or heme that's in the canals. That will kind of improve the accuracy. What I think is a telltale sign if something's off is that it's bouncing around a lot.
Oh, okay.
Yeah, so if it bounces around and you're getting inconsistent readings, then something's off. So you need to dry the area. You can even use a paper point if there's drainage and retake the reading. Another factor is if there's any sort of resorption or if there's a perforation, then it's automatically going to read unread. So
Mm.
that's also kind of a red flag to, hey, I need to stop, take a step back, maybe take a new x-ray, figure out what's going on. If it's reading to red when I'm putting the apex locator on, but I know I'm not down.
Oh, okay.
Yeah.
So do you trust your apex locator more than the X-ray?
Yeah. So like based on
Okay.
studies, it's close to like 99% effective in terms of accuracy. So it's extremely
Okay.
high. Whereas radiographs, there's some inconsistencies based on like the radiographic apex being actually, not consistent with the concentration, the restriction point, which is
Okay.
technically the apical the apex. Yeah.
Okay. Great.
Yeah. Yeah.
And then when it comes to, anesthetizing the tooth so you can do the endo, sometimes it's a hot tooth and you can't
Yeah. Yeah.
anesthetize it. So what are your tricks?
Yeah, so I think the big one is endodontists use way more anesthesia than general dentists. And I see this all
Okay.
the time at U of T with the students because they're giving half carpules, quarter carpules, one block. So my baseline for all anesthesia on lower molars is 4 carpules. So
What?
yeah, 2 blocks, and then I do a long buckle, and then I do a
Okay.
PDL and local infiltration around the tooth. So
Okay.
that's where I start. And that's for everyone. Now, obviously, if there's health issues, I may have to revise that. If it's a younger patient, because I've done some root canals in 6-year-olds, 7-year-olds, then you cannot use that amount. But in most patients, that's totally fine. And that's where I start. And this includes premolars because sometimes students want to do like a mental block and things like that. No, no, you got to do the inferior nerve block, and that's the most effective for lower molars. Upper teeth, I tend to use articaine, septicane, and I do two
Okay.
carpets, one on the buccal, one on the palatal. Patients hate palatal injections,
Yes.
but they're very effective. So, unfortunately, you have to inflict a bit of pain in order to get profound anesthesia, and it does work very well. Every once in a while, I will get a patient that might need an interosseous injection. I
Hmm.
don't know how comfortable most dentists are doing an interosseous injection. It's certainly a skill that you can learn, and it's not that complicated as long as you look at the x-ray, like the radiograph, to make sure that it's safe and you're not going to accidentally pierce the root or something like that. But that is also a technique you can use. I use that maybe once or twice a year. So it's very
Oh.
rare. Yeah. So typically if you err on the side of giving more anesthesia, um, you tend to do better. And also just using different techniques. So sometimes if the IN doesn't work, I will go ahead and do like a Akinosi injection. So just closed mouth technique that works quite well. Um, and yeah, so there's different techniques that you can use. But I'd say the biggest misconception is that you can't start off giving quite a bit of anesthesia. And always check with endoice. So once I've given
Oh.
anesthesia, I will then go, if the tooth is vital, I will check with endoice, not only that tooth, but the tooth next to it. No response, then I can get started. If there's a response and they feel it, then I give more anesthesia. So
That is
that's
such
another
great
technique.
advice.
Mhm.
Yeah, extra freezing to begin with, so you're not trying to do intrapulpal halfway
Yes.
through and the patient's in pain, and now it's even harder to anesthetize him.
Yeah. And
That is
also,
great. And testing with endo ice, that's so simple. I
yeah,
can't believe I never thought about that.
yeah, definitely test with endo ice. And so even if the tooth is necrotic, test the tooth next to it. If it responds, you got to keep going, right?
Okay.
The other caveat is like sometimes, regardless of what you do, they're still responsive. In those cases, I usually send them home, give them pain medication, have them take an anti-inflammatory, bring them back an hour before the appointment, have them take some ibuprofen if they can tolerate it, bring them back and try again. You
Okay,
know,
that's great.
yeah.
And then how about the number of appointments? Are there some cases where you're like, no, you have to come back? And what are those cases?
Yeah. So any case where you can't dry the canal to obturate, you have to bring the patient back.
Okay.
Also, in cases where there's really large radiographic lesions, you may want to bring them back, especially trauma related. You may want to
Okay.
place calcium hydroxide and then bring them back in 2 weeks. You may even want to place calcium hydroxide a couple of times, depending on their response,
Mm.
especially with drainage. So sometimes there's cases where it's really a lot of separation and you have to bring them back, put calcium hydroxide, then bring them back again. I might even re-instrument and then bring them back again, but that's quite rare that you
Okay.
need that. Yeah.
Now,
Yeah.
if there's a lot of separation, do you ever just leave the access open and say, I'm going to let this drain?
No, so that was a common
Good.
convention. It's
Yeah.
definitely kind of fallen out of favor.
Mhm.
So typically you want to establish drainage during like the appointment, do your disinfection, dry as much as possible. If you can't get it to stop, you pack it with calcium hydroxide, cotton pellet, IRM or Cabot, bring them back. Yeah,
Okay, that's
yeah,
good.
yeah, yeah.
And then when it comes time to like doing the actual root canal,
Yes.
any advice on the access? Because your accesses are so tiny compared to the ones we do. So how is it they can get it so small? What are
Yeah.
some tips?
Okay. The microscope is the biggest tip.
Okay.
So I'm in favor, and I say this to the students as well.
Yeah.
Don't put pressure on yourself to be conservative.
Okay.
You're using loops. You don't want to separate a file. You want
Okay.
straight line access. Yes, we use microscopes. It's the biggest hack. We can see everything. It's huge. So yeah, we can get smaller access. But the other
Okay.
factors that you have to think about is most of the cases we're doing root canals on, there's a large restoration there or a massive caries. So
Yes.
by doing a conservative access, you're actually not really conserving tooth structure. Like
Okay.
remove the restoration if you can't see. Like number one thing for especially people starting with endo, you have to have good visibility. You have to
Okay.
be able to get your files in without getting two curvatures because if your file has to bend twice, you're going to separate it. So I would say those are kind of with time, as you gain experience, you can certainly make your access smaller, but certainly when you're starting off, you want to be able to visualize everything. And also for irrigation, you need a larger access. Although there's a pressure to go more conservative, that's a trend right now. Certainly you need to have a microscope to be able to make those little tiny access. And you also need to have a lot of experience in order to feel comfortable doing that and also using the instruments in a way that you don't compromise the case by potentially separating earlier on when you're establishing working length. So you want straight line access, but unlike before, we're not making things divergent. So we're not going to flare the access. We certainly want it to be more flush. And it's more of a orifice oriented approach. So you can make it conservative to a certain point, but as long as you're not compromising visibility and your ability to instrument the canals. The other issue is that we do want to get irrigants into the chamber and down the canals. So if you're really tiny, it's going to be really tricky to do that unless you're using adjuncts like a gentle wave, which is a new, kind of a pressurized system to do irrigation or a laser. So that's the other caveat. A lot of times when we're going smaller in terms of access, we're also using different tools that can help with irrigation, which you might not have access to.
Yeah.
So especially if you're starting on like starting doing root canals, as a beginner, new grad, I would err on just being practical, having enough visibility, ability to irrigate well, and also like use a little bit of a common sense approach. If there's a large restoration, take it out if it lets you see. You have more light that way. You don't need to do a tiny access on composite. You know, I see that a lot, and I'm like, just take out the restoration. Your life will be so much easier, you know?
You always give such great advice. Now, you mentioned a lot of like things that you have that general dentists don't have, like microscopes, endo
Mhm,
activators, like gentle wave.
mhm, mhm.
I feel guilty doing root canals on patients because I think I don't have all that stuff. Maybe I should just refer because that's the that's the new standard of practice. What are your thoughts on that?
So to tell you the honest truth, the evidence doesn't necessarily correspond with outcomes.
Oh,
So
okay.
yes, there are new tools. There are adjuncts often to help you in terms of efficiency, to do smaller sizes, but the long-term studies aren't there yet. So I
Okay.
don't think that there should be any sort of feelings of guilt or, that you should be informing patients that there's all these other different tools that they could. I don't know. We're not there yet. The science isn't there. Long-term studies aren't there. Yes, there's clinical kind of studies that show great outcomes, but statistically, there's not a significant difference, even in the way that we obturate things. So, a lot of us are trained to do vertical warm condensation, but
Mhm.
it's also showed that lateral cold single cone techniques have the same outcome. So,
Wow.
yeah, so a lot of the times it's based on your provider preference, right?
Okay.
What works for you, what works good in your hands, and it doesn't necessarily impact the outcome.
Okay.
So, I certainly think that that should not be something that you should be telling yourself.
Okay.
I think you should refer based on the complexity of the case and your comfort level and your confidence. And also, we had talked a little bit about the number of appointments. If it's going
Yeah.
to take 3 or 4 appointments to do the treatment, maybe it doesn't make sense doing that case.
Okay.
If you really enjoy endo and you want to get more experience and the patient's really cooperative and compliant, sure, go for it. But if it's a case where, you'll be kind of sweating and stressed out and the patient might get upset with you, you might lose the
Yeah.
patient, that's definitely you want to refer out. Yeah.
Good. And speaking of cases, case selection, what are some good cases for new dentists to start with?
So I would limit yourself at the very beginning to anteriors and premolars,
Okay.
ones that are pretty straight, not that curved, not that rotated in the mouth, no crowns on the tooth. So definitely avoid, onlays, crowns, anything like that that might make it difficult for you to access. Those are great cases to start with. But I'd say even more important than that is patient selection. So you want a patient that is cooperative, follows directions, is kind and understanding. I think because everything can go south, even if it's a straightforward root canal, if the patient's putting pressure on you, you
Yeah.
know, why is this taking so long? Why aren't you done? Why are you bringing me back? that
Yeah.
that in of itself can cause problems even if the root canal is easy. So I would say choose a patient that doesn't have a very sensitive gag reflex, who is particular about the way they want things done and doesn't like taking multiple x-rays, and you know make your life easy by choosing a patient that you guys are cooperating together and working on the case as a team.
That's great advice. Case selection, patient first, then think about the tooth. And
Yeah.
sorry that we are referring all those patients to you. So thank you for taking care of them.
Yeah, yeah, not a
Now, here's
problem.
the question I'm sure you get a lot. The MB2.
Yes, and me too.
Any tips on how to find the MB2? Because I often find it, but then I only get my file in 5 millimeters. I'm like, oh, I guess it's a 5 millimeter canal, but it isn't. So give us some tips. Finding it and
Yeah.
instrumenting it.
Yeah, so there are studies, colloidal that 100% of cases and
Okay.
maximolars have an MB2. So there's that study available. Others show 70%. So always go into a case assuming there's an MB2. Now, how to find it is basically it's always mesial, almost always mesiolingual to the MB1.
Yeah.
So you want to kind of move the wall a little bit to the mesial and work your way back. It's also it's often if you draw a tangential line from the MB1 to the palatal, and then go across horizontally from the distal buccal canal, it will be there. So
Wow.
yeah, so that's kind of that's like mentally how I think about it. However, it's really just going a little mesiolingual, but using your Endo Explorer to pick for a little stick in that area. And often you can also visualize it. You might see a little bit of debris. You might see heme in that area. If it's vital,
Mm,
that's a lot easier. And
okay.
then the issue is that often it's calcified, so you have to
Yes.
drill down. And how do you do that? What instruments do you use? So some of the burrs that we have, which are very helpful, you might not have in your practice but you can ask for them. So a Muntz
Okay.
burr is like a tinier little kind of burr that you can use that's long.
Can you say that again? What's it
Called a
called? How do you
Munce,
spell?
Munce. So that's
Oh, okay.
one that we use. I use something called a Manny burr, and it's basically like two slow speed burr, but it's on an elongated shaft. Yeah,
Oh,
and it's not
cool.
aggressive, so I can slowly drill down.
Can you
Um,
spell that one as well?
yeah, it's just
Manny?
Manni. It's a stainless steel
Okay.
burr. It's called Manny.
Oh, I've seen that. Yes.
Yeah, so
Hmm.
that really helps. So basically, you do have to remove often a little shelf, a dentin shelf that is hiding it. Using your and going back and forth between your Endo Explorer and then using burrs. But if you don't have all that, just put a 2 round surgical length.
Hmm.
Use your slow speed. Once you're on the pulpal
Okay.
floor, don't use the high speed. I don't use the high speed. I almost always
Okay.
use slow speed. So there's no shame in that. And then just slowly kind of brush away and see. And then in terms of instrumentation, you want to use, I often at the beginning use a C file, which is a little bit stiffer than a K file. And so it will allow you to get to like you were saying, 3, 4, 5 millimeters. And then I always use a 21 millimeter length hand file, less risk of separation.
Okay.
Eventually I'll move to a 25 millimeter if the canal is long, but first I'll instrument with 6, 8, 10, all
Wow,
21.
6.
You gotta
Okay.
go to six
Oh,
often.
and a C file, that's really handy because it's stainless
Yeah.
steel and stiffer.
Yeah, exactly. Just to
Okay.
find do the coronal portion. I
Okay.
wouldn't put it down the canal because you might ledge and things like that.
Okay.
Use a lot of RC prep and
Okay.
irrigate frequently. You can even kind of put a lot of irrigant in there and just at the beginning, just to get things kind of moving, the debris. But I'd
Okay.
say the biggest thing is that you have to kind of move the wall mesially because often there
Mm.
is a little dentin shelf hiding the MB2
Oh, okay.
and using your Explorer to kind of feel that stickiness and then trace it with the slow speed burr apically. But you got to be
Well, how
careful.
far are you going down with that slow speed
Sometimes
burr?
I go 3, 4 millimeters. So, and
Okay.
incrementally, like I'm not doing it all at once. I'll
Yes.
go, I'll pick, I'll go, I'll pick, I'll use the hand files. And then if I can't get the hand file down, I might remove a little bit more. But the other thing is, if it's that calcified, sometimes it doesn't matter. Doesn't make a difference. So that's the other thing. So you can tell the patient, I found this extra canal in your tooth, but I'm not able to instrument it all the way down. It's heavily calcified, and you can monitor the patient. And
Mm.
if something happens in the you can ask them, I can either refer you and I have someone take a look at it, but usually I'll,
Yeah.
let's see how you do over 2 weeks. If the tooth remains symptomatic, then we can refer you. And there are
I
many
didn't know you can do that. That is great, Sarah.
even endodontists do that. You know, there are cases
Oh,
where I do a scan, I don't see an MB2 canal, but when I clinically
yeah.
go into the tooth, I can see it. So I'll try
Mm.
to chase it, but I can't get a file down. I'm stuck at five
Yes.
millimeters. So, you know, sometimes you can't do it. It has to be done surgically. There's
Okay.
nothing you can do. It doesn't matter what instrument you use. It's not on you. It's the body's way of producing, you know, calcium deposits, and it will need a surgical intervention if there's a problem, which there may never be.
Okay.
Yeah.
Okay.
Yeah.
So just
Yeah.
going back to the C file, those stiffer files, how far can you put them down before you should switch to a K file?
Yeah, so typically I just use them to gain access to the orifice. So in cases
Oh,
where it's
okay.
calcified, so I'll put, you know, you can go down 5 millimeters. I just,
Okay. And then,
as long as you're not using the file to the, like if you know you're not down, you have an established cadency, you don't want to use repetitive movements at a short length because that's how you
yeah.
create ledge or block
Okay.
it, right? So as long as you're seeing that you're progressing, you can still let it go down. But normally I'll use it in the first 5, 6 millimeters, and then I'll switch to this just a regular K file, a 6, try to get that further down and progress up. Once I can get into the canal, often things start to move faster.
Yeah, that's
Yeah,
true.
yeah, yeah.
So tell us about your irrigants.
Yeah, so you know, there's a couple different options. So I use, you know, sodium hypochlorite. When I was practicing in the US, we use full strength.
Yes.
Um, in Canada, definitely or at least in Ontario, the convention is to dilute it 50-50. From a legal perspective, stick with the 50-50.
Okay.
There are studies that show the outcomes are better with a higher percentage, but just from a safety perspective and our regulations here, you want to kind of play on the standard here.
Okay.
So you want to dilute your sodium hypochlorite, and you want to use that throughout the procedure. But normally when I'm using hand files, I'll use RC prep because there's some EDTA in there, so it helps with the calcifications. Definitely don't want to use that though with rotaries because it does clog the flutes. So make sure
Oh,
you
okay.
irrigate before with your sodium hypochlorite before starting to use the rotaries.
Okay.
Um, and then, so that's I mainly use sodium hypochlorite throughout the procedure. And then I do a final rinse where I start to use other things. So normally I use Q-Mix, which is basically like Dentsply. It's a combination of chlorhexidine, as well as a chelating agent, like, you know, so it basically prevents the formation of a precipitate that we don't like. So I use that. It's one step instead of having to use multiple steps. And your other option, some people use EDTA, and then maybe then they'll use chlorhexidine. You can also, some people also like to use alcohol as a final rinse, but I like to keep it simple. So I just use the Q-Mix, and that acts as a killing agent and also as a antimicrobial. So that's kind of my choice. I also use the endo activator, that, you know, makes me feel better about the irrigant. So it's passive kind of sonic activation. But there's so many different techniques and tools that you can use. So, you know, I can't necessarily say one is better than the other. But certainly you can add chlorhexidine in there, you can add Q-Mix, you can use EDTA, but you have to be a little cautious about using EDTA in calcified canals, because it can kind of increase your risk of like stripping the canal or like transporting it. So you have to be very judicious, maybe put a little bit if in the top in the coronal portion, but don't continuously irrigate with EDTA,
Yeah.
especially if you're not progressing in the canal. Because if you continuously do it, you're probably going to
Okay.
perforate. Yeah, yeah.
And what type of obturation technique do you use?
Yeah, so I use the warm vertical condensation,
Mhm.
but I was trained at NYU to do just a single cone technique, initially, and cold laterals, combination of those
Yes.
two. And you know, when I was a general dentist, I would use a single cone technique. I would sear at the very top just to make
Yeah.
it pretty. And I would use bioceramic sealer, and
Okay.
that kind of made me feel good. And
Yeah.
it's very fast, it's very efficient, it's very practical. And, you know, in terms of long-term studies, there's not a huge significant difference between those techniques. But theoretically, you know, doing warm vertical, you get a three-dimensional kind of continuous
That's
fill. So I like using that technique now that I'm more comfortable, after doing residency and doing all these cases with that and now in practice. But I certainly think it's best to use a technique that works well in your hands, or if you're working in a practice, whatever they provide. I'm not a huge fan of techniques that are carrier based for
okay.
obturation, just because, clinically I've seen quite a few failures
Oh,
with carrier-based systems. And they used to also use this other system called Resilon, which was almost like a
mhm.
liquid solid fill. And that was like very cutting edge, maybe 15 years ago or 20 years ago. And they ended up all failing. So, I would just be hesitant to use kind of newer technologies in obturation. If something comes out, I would wait a while before adapting to it. Um, so it's really clinician's choice in terms of how you want to obturate, but I do
Okay.
have a preference for the warm vertical, just from a theoretical perspective.
Okay. That's
Yeah.
good. I like the evidence-based information there. And how about afterwards? If the patient has a lot of symptoms, how do you manage that?
Yeah, so when I'm doing the informed consent, I warn
Yeah.
them of an endodontic flare-up. So I tell them
Okay.
7% of patients will develop severe pain and swelling after a root canal.
Yes.
And if that were to happen, please call us right away. I will prescribe you antibiotics and some additional pain meds if needed, and I'm going to bring you in for a follow-up. So
Okay.
that's in my informed consent. My patient, sorry, when you call the next day, your patient, or maybe the staff, your front desk staff calls,
Mhm.
we go through a checklist of asking questions about pain and things like that, just to make sure that the patient feels supported. But then when you have to manage it, normally it's just, typically my favorite antibiotic to give is, if there's a swelling, is clavulin, 875,
Okay.
14 pills, take twice a day with food, breakfast and dinner. And then I usually say
Okay.
something about like also take it with yogurt or a probiotic, just to
Okay.
kind of help with stomach upset. So that's typically my go-to antibiotic for any sort of facial swelling. Now, sometimes patients will say, oh, my gum is swollen or something like
Mhm.
that. And normally I just tell them, like, I had a clamp there, so it's probably going to be a little bit inflamed. Can you, rinse with salt water? If
Okay.
it continues to bother you, like come in for a follow-up. So I would say my kind of strongest suggestion of how to manage patients that are in pain afterwards is validate their feelings. Make sure that you understand what's going on in terms of the swelling. Is it a facial swelling, or is it like a little inflammation around the gums? Ask them to kind of rate their pain from 1 to 10. And then always offer a follow-up appointment where you can
That's
see,
great.
like, that's kind of the most defining thing. Because if they don't have that opportunity, they feel that you're ignoring their pain. And
Yeah.
that's when things start like compromising the therapeutic alliance.
Yeah. That is great advice. I like how you do the follow-up phone calls
Yeah,
and
yeah,
that, yeah, offering another appointment. They might say no, but at least you're offering it to
exactly. And that's
them.
really important to at least give that offering of, hey, we'd love to see you. Let me see what I can do to make you feel better, you know?
And do you ever give them prescription beforehand when they leave, like for pain medications, or do you just wait and say, okay, now I've done the follow-up call, you're in pain, now we'll give you something.
Yeah, so I very rarely give
Mm.
anything other than like recommend Advil and Tylenol. So
Okay.
in my post-op form and verbally, I tell patients, like, take 500 milligrams of Advil and, or 600 milligrams of Advil and 500 milligrams of Tylenol if you have kind of moderate pain, over-the-counter medication, whatever you're comfortable with. But usually I say take it before the freezing wears off, at least the
Oh,
first dose.
good.
Some
Okay.
patients are very reluctant to take medication, but I try to get them to at least take the first dose before the freezing wears off, to preemptively kind of stop the pain from happening. But yeah, if I don't really prescribe anything stronger, unless there is an actual endodontic flare up, and then I
Okay.
usually will do like Tylenol 3
Okay.
along with Advil. Yeah, and I
Okay.
just let them know they might be drowsy. So, or sometimes I have to write no caffeine, because sometimes Tylenol 3 has caffeine in it, and then they can't sleep.
Yes. Yeah, that's right. Good
So just,
point.
yeah, just to be
Mm.
cautious of that. But most patients are fine with Advil and Tylenol,
Okay.
unless there's some chronic pain issues that they have, and so maybe they might not respond well.
And you like the combo where they take 600 milligrams of ibuprofen and 500 milligrams of acetaminophen at the same time.
Yeah, that's my
Yeah.
preference. Yeah, yeah, for
Excellent.
sure. Oh,
Thank
the
you.
other thing I'd say,
Yeah.
worst case scenario, if they're not responding to that, you can prescribe Ketorolac or Toradol.
Okay.
Yeah,
Great.
yeah. Obviously check the, the medical contraindications, but that's
Hmm.
also works. A lot of people would argue that it works better than Tylenol 3.
Yeah, and without all the side effects. So that's great.
Yeah, yeah, exactly.
Now, finally, one of the questions that new dentists have a lot is about work-life balance. And I thought this would be a perfect question for you because you're a specialist, you're a practice owner, you have a young daughter, and you have a dog. How do
Yes.
you do it all?
Okay. Well, it's a work in progress. I wouldn't say I'm doing it all, but I think having grace for yourself,
Okay.
having some grace and understanding that I can't do it all, right? I get it's not
Okay.
possible for me to do it all, but pacing myself, understanding my limitations, and also, honestly, working on my mental health is a huge component of it.
Good.
So
So
I'm a
how do you
big
do that?
yeah, so I'm a big believer in therapy,
Good.
so, if especially if you have like the ODA extended health plan, there are some therapy
Yes.
sessions in there.
Yeah.
So, seeking out therapy, even like working with a social worker, doesn't have to necessarily be a psychologist
Hmm.
or, you know, but being able to discuss coping techniques, stress management. I try to play tennis a couple times a week. That gets out some of my
Excellent.
anxiety. Um, and
And you're
lowering
doing something you love, so that's good
yeah,
too.
exactly. It's fun, getting some of those endorphins released.
Yeah.
And then also it's about the team that you work with, right? So it's not
Hmm.
necessarily like it might be a stressful environment because, maybe a patient's upset or something like that.
Yeah.
If I have a good supportive team, and I also have
Yeah.
colleagues like yourself that are very
Oh.
kind and supportive, and I can vent to them, it makes such a
Yeah.
huge impact. Now, in terms of being a mom and a dog owner, there are some compromises, right? So, like, I ask for help. I ask for help
Yeah.
from family. I have a babysitter that works with me.
Mhm.
I also have to tell myself, like, yeah, you're not going to see her tonight. She's going to be in bed by the time you get home, but that's okay
Yeah.
because you can see her on the weekend, you know?
Good.
So just kind of managing my expectations and not putting so much pressure on myself and including with patient outcomes,
That's
like
true.
reminding myself I can't control it. We're really controlling like
I know it's true.
dentistry, but you can't control the outcome of things. So you know what? It's okay. Sometimes things fail, and it's really about how you manage the patient and how you treat them afterwards and how you follow up with them. That determines, if they still want to stay with you and if they want to give you another
Yeah.
chance, right?
And
Yeah.
that is you gave us such great advice, not just on how to treat the patients, not just on how to treat the tooth, but how to treat ourselves. Like I love how you started off by saying we have to give each other grace. We have to give ourselves grace. So
Yeah.
thank you for
Yeah.
giving us such great advice for our mental health and also for our endodontic treatment. So I love my conversation with you, Sarah. How can the listeners contact you?
Yeah, so you can certainly Google our practice. It's River Street Endodontics, and I have my email address on there. And I'm always happy to answer questions or even look at cases. You could also reach out to us on Instagram. We have an Instagram account, and I'm happy to help you in any way that I can.
And we're happy to have had you on the podcast. Thank you, Sarah. And thank you to everyone who's listening. Bye.
Bye.
This podcast is sponsored by RDT Dental Laboratory, your full service dental lab in Toronto. RDT Dental Lab will help you grow your practice through education, predictable restorations, and high attention to your clinical needs and patient experience. Check them out at rdtdentallab.com. Thank you for listening to the New Dentist Study Club podcast. Listen to us on Spotify, watch us on YouTube, share and subscribe, and follow us on Instagram at New Dentist Study Club.